Now let us discuss the questions on cor pulmonale. The first case discussion, a 70-year-old man came with the complaints of swelling of both legs since 6 months. He had intermittent wheezing and chronic cough for several years. He had been using over-the-counter inhaler on and off. He had a history of smoking 1/2 pack of cigarettes daily for 50 years. His pulse rate, blood pressure was normal, JVP was elevated, he had a barrel-shaped chest, abdomen is distended, pitting edema is present. What is the most probable diagnosis? So let us analyze the case. First of all, the age is 70-year-old. Complaints are swelling of both legs. Now, whenever you have edema of lower limbs can be because of severe anemia, it can be because of liver failure, heart failure, renal failure, or hypoproteinemia. So, here we are going to analyze what is the cause of all these. Now, the next hint they are giving is that he had been having intermittent wheezing and chronic cough. So, it means that there is some problem pertaining to respiratory system. And then they have given that he had been using counter inhaler, so over the counter inhaler. So which means he had been having breathlessness on and off, for which he was using inhaler. So what has triggered this? They have given that the risk factor was smoking almost for 50 years. So when a person smokes for 50 years and person complains of wheezing, we obviously think about COPD. So COPD, yes, it is present. This we are assuming. Now the next hint they are giving is JVP was elevated. So when we mean that the JVP was elevated, then this means that there is going to be some amount of disturbance in your right heart. So there is going to be your right heart problem. So there is problem with your right heart. Fine. Now they have given that he had a barrel-shaped chest, and you know barrel-shaped chest is present in COPD. So therefore our assumption is right. So the person has got COPD. Now they have also given abdomen is distended, pitting edema is present, which can also be seen in your right heart failure. So therefore here you have COPD and you have the right ventricular dysfunction. So when you have the right ventricular dysfunction next to COPD, it is nothing but cor pulmonale. So which you know we have discussed already in the previous video. So therefore this condition is cor pulmonale. So where they have given the complaints indirectly. So they have given that they have been wheezing. So the person was having COPD is revealed indirectly. So this points to cor pulmonale. Moving on to the second case. A 60-year-old man with a known history of COPD presented with the complaints of dyspnea on exertion, swelling of limbs. He had been having abdominal discomfort and distension. There is no history of orthopnea or PND. On examination, pitting edema was present in lower limbs, JVP elevated. There was a palpable heave in the fifth intercostal space just to the left of the sternum, and auscultation revealed a hollow systolic murmur, loudest at the left lower sternal border. Abdomen examination showed hepatomegaly and ascites. ECG showed right axis deviation, echo showed right ventricular hypertrophy, tricuspid regurgitation is present, BNP levels were elevated. So analyzing this case, again old age, they have directly given that the person had COPD. So primarily lung disease is given. Now they are telling that the person complies with dyspnea on exertion and swelling of limbs, abdominal discomfort, distension. So there is something to do with your right heart. Now your examination findings are also in support of that, like your pitting edema, JVP elevation, and they have given palpable heave. So palpable heave is seen when there is hypertrophy of your right ventricle. And they have given that you can hear a hollow systolic murmur in the left lower border, which points to tricuspid. So there is tricuspid regurgitation. And physical examination is also confirming the involvement of your right heart by showing hepatomegaly ascites, which is again further confirmed by your ECG and echo, which is showing your right ventricular hypertrophy, tricuspid regurgitation, and BNP levels elevated. So here you have some problem with your right ventricle, and they have given the primary lung disease was COPD. So whenever you have this pulmonary and the heart involved, so it is your pulmonary heart disease, which is nothing but your cor pulmonale. So therefore, the diagnosis is cor pulmonale. Moving on to the MCQ, cor pulmonale is seen in marked opacity, kyphoscoliosis, massive pulmonary embolism, all of the above. As we discussed under the etiology, yes, marked obesity causes. Kyphoscoliosis, yes, it affects the chest wall movement. Massive pulmonary embolism, yes, it affects the pulmonary arteries. So, therefore, your answer is all of the above. The next MCQ, in a patient with dyspnea and fatigue on exertion, cor pulmonale due to COPD is suspected. Which of the following imaging studies is appropriate to evaluate RV function in this patient? So we want to evaluate RV function. Now chest X-ray can tell you whether there is cardiomegaly, they can tell you whether there is hypertrophy or not. But it cannot assess the thickness, it cannot assess the further detailings about your RV function. ECG, yes, it can give you a broad idea. But if you want to have a very good imaging with the motion and all that, it should be with echocardiography. So the answer to this MCQ is echocardiography. So that completes the discussion on cor pulmonale. Thank you.